I did my finals last year. Just want to apologise for my voice, just in case my voice goes today. I got a bit of a sore throat, so sorry about that. So I'm going to be doing a quick talk about IBS, IBD and stomas. So I've focused the majority of the talk on IBD, so Crohn's and ulcerative colitis, but I've added a bit in the end about IBS and stomas as well. So simply, IBD is just an uncontrolled inflammatory response to cytokines that happens in the digestive tract, and it causes a destruction of healthy cells to occur. Okay, something that I found really useful for my finals or just throughout medical school is just to compare ulcerative colitis and Crohn's against each other to find out the differences. So you can see here you've got your prevalence. So ulcerative colitis is about twice as common as Crohn's. I wouldn't go memorizing those, just know that ulcerative colitis is more common than Crohn's. And then something important to remember is that the age range of ulcerative colitis and Crohn's. So it normally happens in the younger population, but ulcerative colitis, you've got your bimodal onset. So you've got your two groups. So most common is about 15 to 30 years. And then you've got another onset about 50 to 70 years as well. An important thing maybe to remember about ulcerative colitis is it normally always happens after puberty, whereas Crohn's, most common in the early 20s, but it can also happen in early childhood, and that's before puberty. So 9, 10, 11, 12 are common ages to have it as well. I've put sex here. It's not an important part. It is slightly more common in females, but it's not very significant, so I won't go remembering that. It can happen in both females and males. It's more common in females, say in this 15 to 30 or 10, 11, 12 age group. Okay, another big difference between ulcerative colitis and Crohn's is smoking. So in ulcerative colitis, smoking is actually shown to be protective, though it's not recommended by anyone who's got ulcerative colitis to start smoking, because obviously you've got the other risks, respiratory risks and everything else on your body, but it has actually been shown to be protective. However, in Crohn's, it is shown to increase risk of Crohn's, make relapses worse, make them relapse more. So it's the complete opposite there. So similar things between the two. Both have you can have a strong family history for ulcerative colitis or Crohn's. So it can go across both. So say your uncle had Crohn's and you can develop ulcerative colitis. It doesn't just mean if you've got Crohn, an uncle's got Crohn's, you can only get Crohn's, you could get ulcerative colitis either. So these are autoimmune conditions. So they can be linked to other autoantibodies. So HLA-B27 positive. So that's normally seen in ankylosing spondylitis. So some people with ulcerative colitis also are HLA-B27 positive. Another risk factor for ulcerative colitis is high use of NSAIDs, and then also high use of antibiotics in childhood. I think that's quite a weak link though, but it's still to be noted. And then being of white European descent is shown to be a higher risk for ulcerative colitis or Crohn's. Okay, so again, if we move on to just comparing the two. So the big difference between the two is that ulcerative colitis only affects the rectum and the colon, so it's up to the ileocecal valve. So you can see my arrow here, so the rectum, sigmoid colon, up all here, and it stops here, so ulcerative colitis. Crohn's can affect anywhere from the mouth to anus, so right down here through the stomach, small intestine, large intestine, sigmoid colon, rectum, can affect absolutely anywhere. So that's a major difference between the two. The distribution is also a major difference between the two. So ulcerative colitis starts at the rectum, and then it goes up, and it just continues right up. There's no skipping, it's continuous. So it always starts at the rectum and then creeps up. Crohn's, you can have inflammation at the rectum, then you can have some in the small intestine, some in the mouth, the esophagus, the sigmoid colon, anywhere. So that's called your skip lesions. So that's an important distinction to remember between the two, okay? Another important distinction is your layers of inflammation. So ulcerative colitis is quite if you want to call it, quite superficial. So it only affects the mucosa, so that top layer. But Crohn's affects all the layers. So down, if you want to split them into 3, down to the 3rd layer. So that's called transmural. So it's a lot deeper. Okay. Also, colitis also doesn't really have strictures, so that's narrowing of the bowel, whereas you can see that in Crohn's. Okay, I will go over these later. These are just some obvious differences that we've got. You also get pseudo polyps in ulcerative colitis. You can get some in Crohn's, but they're characteristic of ulcerative colitis. You can get fistulas in Crohn's, so that's an abnormal connection between 2 epithelial surfaces. So you can get a fistula between 2 parts of the bowel, so they connect, or you can get the bowel that connects to the bladder. So then you get fecal matter coming out through the urethra, things like that. But you don't really get them as much in ulcerative colitis. And then what else can we see there? Ulceration. So it's called cobblestone mucosa in Crohn's. Like I said, I'll go over this in a second. Okay. So when we're looking at a patient and we want to make our diagnosis, so we're first starting, someone comes in to see you, and this is the history, okay? So some key symptoms we're looking out for. So Crohn's, we're looking for watery, non-bloody diarrhea, okay? The reason this happens is because the intestinal wall's inflamed. So then the cells get damaged, they burst and release their water. So the water goes into the fecal matter and causes diarrhea. You can also get malabsorption because it affects the large intestine, the colon, and that's where the water is absorbed. So the colon can't do its job. So again, water enters the fecal matter and you get diarrhea. Okay, we'll carry on with Crohn's and I'll go over to ulcerative colitis. So Crohn's, on the flip side, you can seem to be constipated due to strictures, so that's narrowing of the bowel. So that's caused by scar tissue due to inflammation, a lot of inflammation. So they get obstructive pictures. So if the stricture is, say, in the small intestine, they're going to be vomiting, they're going to be bloated, they're not anorexia, they're not going to want to eat. If the stricture's in the large colon, you're going to get that constipation, you're going to get tinkling of bowel sounds, and you're going to get that bloatedness again. So you have to remember that sometimes it's not always diarrhea, but they probably have had a history of diarrhea before they've got this stricture. You also get abdominal pain. So this is going to be in the lower right quadrant the majority of the time. So like I said, Crohn's can affect anywhere from the mouth to the anus in the GI tract, but it most commonly affects the ileocecal valve. So that's between the small intestine and the large intestine, that valve there between the ileum and the cecum. So that is in your lower right quadrant, and that is the place where it affects the most, about 50 to 60% of Crohn's sufferers. So you're looking out for, it can be anywhere because it affects anywhere in the GI tract, but lower right quadrant you're thinking of. Now, because it can affect the mouth and anywhere from the mouth to the anus, you can also look for mouth ulcers. So I know in exams they like to put, it sounds like it's going to be ulcerative colitis, and then they put at the end like, oh, he's also got 2 mouth ulcers. So straight away you go to Crohn's because ulcerative colitis doesn't affect the mouth. And then anything like perianal lesions or anal fissures, anything like that they might report to you. Okay, then we move on to ulcerative colitis. So one main difference here is you tend to get bloody diarrhea in ulcerative colitis. You can get bloody diarrhea in Crohn's, but it's not as common, and it's almost nearly 100% that get bloody diarrhea in ulcerative colitis. So that's a major difference there. You can get mucus in the stool, and then you're getting your abdominal pain or your abdominal discomfort. But this is probably going to be in the left lower quadrant. This is because the rectum and this sigmoid colon is the most commonly affected, and that's in your left lower quadrant. Because remember, we're starting off at the rectum and then we're going up, so it's always, the left side is always affected. You can get tenesmus, so you feel like you need to open your bowels a lot and go to the toilet. It's just a feeling like you need to go. And then you can get urgency and nocturia. So I don't know if you use the right word there, but feeling like you need to open your bowels in the night, and you can get that with Crohn's as well. Sorry, that should have been in this section. So in both, you can just get fever. So if there's inflammation, feeling unwell, malaise, just feeling generally unwell, anorexia, and weight loss. An important thing to remember in weight loss is that this condition obviously affects younger people quite a lot, especially Crohn's. So you need to think, if a 9-year-old is presenting with weight loss, this is going to be called failure to thrive. And you need to think about how you can get that nutrients back in so they can keep growing. Okay. So some differentials we can get from those symptoms straight away. So if you're seeing someone in GP and they come in with those symptoms. So right iliac fossa pain, that could also be appendicitis. You've got left lower quadrant pain. So that could also be diverticulitis. Increase in frequency and mucus in stool. Sorry, 1 second. Sorry about that, my voice is going. So this can be IBS, so we'll talk about that after. And then any change in bowel habit, that could be colorectal cancer. So you need to ask about family history, any night sweats or rapid weight loss there. So next you do your examination. So you're going to, sorry about this. So you're going to do an abdominal examination. So in ulcerative colitis and in Crohn's, you might see a tender, distended abdomen. So again, in ulcerative colitis, it's probably going to be tender in the left lower quadrant. And in Crohn's, it's going to be the right lower quadrant. In Crohn's, you might feel a right iliac fossa mass. So this might be due to a stricture that's caused obstruction, and you've got fecal matter building up in the right iliac fossa. If you do a PR exam, you might see anal strictures or any perianal abscesses. Extra-abdominal signs. So this is an autoimmune condition, so you can see lots of other autoimmune things. So in the nails, you can see clubbing. Then on the legs, you can see erythema nodosum and pyoderma gangrenosum. So pyoderma gangrenosum is seen more in ulcerative colitis. Then in your eyes, you can get iritis, episcleritis, and conjunctivitis. In your joints, you're getting arthritis, and like I said before, ankylosing spondylitis. And then you get more in the hepatopancreatic biliary system. So you can get an increased risk of cholangiocarcinoma, so that's cancer of the biliary tree. And you can get primary sclerosing cholangitis as well, so that's seen more in ulcerative colitis. Another one is gallstones, that's seen in Crohn's. That's due to malabsorption of bile salts a lot of the time as well. Okay, so you can get complications of IBD. Okay, one major complication that everyone always remembers is toxic megacolon. So in examination, you'd see a loss of bowel sounds, you'd see a distended abdomen. You can do an abdominal x-ray and you'd see the colon has a diameter of more than 6 centimeters. So it's just stretched and stretched. All the cells have died and it's just no longer functioning. It's just staying there. It's full, can be full of fecal matter, everything. So there's a massive risk of perforation with that. So this is a surgical emergency, okay? So you can first start off treatment. So that's decompression of the bowel to remove the air, but if that doesn't work, then you're going to have a total colectomy to remove the whole of the colon. So that's a surgical emergency there. You can also have bleeding. Like I said, you get rectal bleeding, but also you can have a major bleed, so you need to keep an eye on that. Malignancy, so I'd already said about cholangiocarcinoma. So compared to a person without IBD, you've got about a 4% greater risk of developing cancer of your biliary tree. And then you've got colorectal cancer as well here. So about 15% of people who have had IBD for over 20 years develop colorectal cancer. So Patients who have had patients who have ulcerative colitis, it's normally in, or Crohn's, should be offered a colonoscopy every 3 to 5 years to check for colorectal cancer. If they are high risk, so that means that their whole colon's affected in ulcerative colitis, or their treatment's not working, they need to have a colonoscopy every year to check for colorectal cancer. Like I said before, it's strictures that can lead to obstruction. You can have fistulae. So quite a lot of people get these in Crohn's. Like I said, you can have the colon to the bladder, so that increases frequency and increases the risk of UTIs as well. You can get abscesses. And then a major thing in Crohn's, like we said, with about failure to thrive, is malabsorption. It doesn't really happen in ulcerative colitis because the small intestine isn't effective in ulcerative colitis. So this is something happening in Crohn's. So you get malabsorption of fat, at least the steatorrhea, so that's your fatty, light-coloured floaty stools in your toilet pan. You can also get gallstones. You get malabsorption of vitamin B12, so that leads to megaloblastic anemia. You can get malabsorption of vitamin D, so that's osteomalacia, and malabsorption of proteins, that leads to edema, because a protein is what keeps your water in your cells. Okay, so we've done our history, we've done our examination. So now we want to be doing some investigations. So obviously you'd start with your normal observations. So check heart rate, check breathing rate, check temperature, everything like that. And then you'd move on to bloods. So the major ones we want to do are FBC. So that would show a low hemoglobin, and that's in more severe disease. That could be due to a lot of bleeding and ulcerative colitis. And then an increased white cell count. You'd also do your LFTs, so that can show low albumin in severe disease. You'd have increased CRP and ESR, and it's normally ESR that's used. It's using something later that I'll show you. And then you'd want to take blood cultures as well. You'd also do some stool investigation. So you want to exclude other infections, such as Salmonella, Shigella, or Campylobacter. And then you do a test called fecal calprotectin. So this shows that if the bowel is inflamed, so it's not necessarily just for IBD, because it could show for colorectal cancer as well, but it's used a lot in IBD clinic. I'll talk about later how if the fecal calprotectin is raised, that means there is something going on in the bowel. So it excludes IBS basically. Okay, and then we want to move on to our imaging. Okay, so in both we want to do a chest x-ray. So that's looking for perforation, so you're looking for free air under the diaphragm. You could do an abdominal x-ray like we talked before. You can look for megacolon and ulcerative colitis. So you see wall thickenings and you see loss of Huygens markings, so that's the lines that are across the colon. In Crohn's, you can do a CT abdo pelvis to look for fissure or obstruction or strictures. You can also do an abdominal x-ray with a barium emmer. So that's to look for strictures as well. The gold standard in both Crohn's and ulcerative colitis is going to be endoscopy. So in ulcerative colitis, mostly just a flexible sigmoidoscopy is needed because it's only in the rectum and sigmoid colon normally. So that's going to show pseudo polyps, and it's going to show continuous lesions, so no skip lesions with uniformly flamed mucosa. And remember, it's only the first layer, it's not transmural, it's just on the first layer of the mucosa. So it should be uniformly inflamed. On Crohn's, you probably want the full colonoscopy, and so that obviously that will just show it in the colon. So you're looking for cobblestoning, you're looking for skip lesions, so part of the colon's inflamed and other parts aren't. And then there's also something called the string sign of Cantor. I don't think I knew this for my finals, it's just when I was doing this teaching I found it. So that's narrowing of the terminal ileum. So obviously that's where it's mostly found. And then another gold standard is histology. So in Crohn's disease, you get non-caseating granulomas and giant cells are found. And also colitis are crypt abscesses with granulocyte infiltration. I remember just learning this point for my finals here, non-caseating granulomas. I don't think I knew the rest, and nothing else really comes up. That's the one that they always like to use in a patient's history. Okay, so there's some criteria called True-Love-and-Width criteria that test for ulcerative colitis severity. So there's 6 points to remember, but again, if you just definitely remember bowel motions and PR bleed. I think that's the most important parts. If there's just 2 parts you're going to take away from this. So quite easy to remember, mild is less than 4, moderate is 4 to 6, and severe is more than 6. So this is used for treatment, which we'll go over in a second. Okay. A PR bleeds, you've got small, moderate, large. And then maybe I would remember the ESR as well. So you've got less than 30 for mild and more than 30 for severe. The heart rate is just, I mean, over 90 can be normal for some people, so it's very subjective. And hemoglobin, I don't think I would remember, wouldn't bother. Right, management. So management for IBD, there's 2 major parts. You've got induction of remission and you've got maintenance of remission. So they are quite different. So we'll start with ulcerative colitis. So you've got your mild or moderate. So if we go back, so that's your less. So 1 to 6, and your small to moderate bleeds there. So you're looking for topical recto-aminosalicylate. So that's your 5 ACEs. So that's something like sulfasalazine. There's a few others if you can look up if you want to. So you use that. So straight away you use your topical. That is the most effective. Some patients don't like using topical rectal things, so they're offered an oral aminosalicylate instead. It's not actually it's found to be not as effective as your topical one, but some patients just prefer it. If after 4 weeks, so remember this is your mild flare up, so you try something and then wait a couple of weeks, see if it's working. If it's not, you add on. So if just your topical by itself isn't working after 4 weeks, you can add your oral aminosalicylate. Okay. If that's still not working, your last resort for a mild to moderate is to add a topical or oral steroid. Okay. So it's just a short course for this. You don't want anyone to become reliant on it, and obviously steroids have their own side effects and withdrawals and things like that. So severe, so we're looking at our major bleeds or more than 6 bowel movements a day. So straight away, straight to hospital if it's really severe, and they're treated with IV corticosteroids, okay, for at least 72 hours. And then we look at their symptoms after 72 hours. If they get better, perfect. We see if we can move them down the scale. So if we can move them to oral corticosteroids and then your topical aminosalicylate. If there's no improvement after 72 hours, we might try intravenous cephalosporin. So that's it's used in like organ transplants. It's like an anti-rejection drug. So that's only last resort after 72 hours. And then if there's no improvement, we might consider surgery. So some indications for surgery when they come into hospital are stool frequency more than 8 times a day, pyrexia, extreme tachycardia, low albumin, because that's only seen in the really severe, and then if they've got toxic megacolon. So they can have surgery. Surgery would be removing the whole of the large bowel, so up to the the first bit of their remaining bowel will just be the ileum of the small bowel. You have to remember that because ulcerative colitis only affects the large bowel, this surgery is actually curative for any of their bowel symptoms. So some people, if they keep relapsing, this is what they want. You have to remember that obviously ulcerative colitis, autoimmune disease, that affects other parts of the body. Like we said, you can have other signs and symptoms. So that won't cure that part of it, but it will cure your bowel symptoms. Okay, so yeah, someone was just asked, any one of those indications that will qualify for surgery. So it really depends just on the on the patient. So obviously, it's more stool frequency more than 8 times a day that's not being controlled by your corticosteroid, that's not being controlled by a cephalosporin, and it just depends on what the patient wants as well. So they could try a new medication. But obviously, toxic megacolon, that's definitely an indication for surgery. It just depends on the patient. Probably tachycardia by itself won't be an indication, but obviously you want to check if they've got an infection, if it's sepsis, what's going on for that one. Hope that answers your question there. Okay, then we move on to Crohn's disease. So straight away induction of remission. So this is a bit different. You start with your corticosteroid. So that's your, I always just say prednisolone. That's easy to say. So we start quite high for Crohn's because it can get quite severe. Like we said, it can happen in children. So we need to add in some nutrition, enteral nutrition, if there's concerns about growth. So it depends how severe it is. So you can add in, obviously, if the small bowel isn't working, you might need to add TPN. So that goes, that bypasses your small bowel there and gives the patient nutrients. If steroids are contraindicated, you add your aminosalicylate there. If this isn't working, you move down to the next step. So add, sorry, I'm really bad at pronouncing drugs, but azathioprine or mercaptopurine. So this is if there's 2 or more inflammatory exacerbations in a 12-month period. So that's an important fact to remember there. Okay. The reason that this is used second over the prednisolone is because some patients can have a auto-recessive condition that, and then you need to measure there, it's called a thiopurine methyltransferase activity. So you need to measure that in patients that are going to go onto these medications. Some people can have a recessive condition where this activity is really, really low. So this is called it causes a buildup of these medications, and then you can get neutropenia, so their immune system isn't working. So this is something that needs to be checked before the patient's got on this medication. Okay, if you come in Crohn's disease and it's really, really severe, it's not working with any of these other treatments, you can give monoclonal antibodies, so something like infliximab. Okay, this is given as a last resort, or if, say, this is their 10th in a year flare up. Okay, they need to be on this for at least 12 months. It can't be, we'll do this until we've induced remission and then we'll stop and go on something else. This is given for at least 12 months, or if it doesn't work, obviously then you stop it. There's no point being on them on it if they've tried it for a while and give it. So it's only given if there's clear evidence of ongoing disease. So it's only given those last resort. Last resort is surgery. Okay, unlike in ulcerative colitis, surgery is curative in the majority of patients. Crohn's disease can affect anywhere from the mouth to anus, so it's not going to be curative. They won't have their large colon symptoms anymore, but it won't be curative for them. Okay, so your next bit, you've got your maintenance of remission. So also colitis is very similar to your induction of remission. So again, you've got your topical aminosalicylate. So again, that's your sulfasalazine. If it's not working for a patient or they don't like it, they can move on to the oral version. Again, it's not quite as effective. If they've had a severe relapse recently or 2 or more exacerbations in a year, they can go on to mercaptopurine, or this is the one that I can't pronounce, sorry guys. So they can go on that. Again, they need to be tested for that autorecessive condition for the activity, so they don't get any neutropenia. Crohn's disease, again, similar. We do not give, an important thing is do not give glucocorticosteroids for maintenance. we don't want to give steroids for maintenance at all. You can have major effects on the adrenal glands and can cause many effects, such as when they're not got enough steroids in the body, say if they come straight off it. So we want to try and avoid steroids as much as possible. So you can give your mercaptopurine again, or this one I can't pronounce again. And again, you need to test them for that autorecessive condition. Some patients are given methotrexate to induce remission. So if they are, they can use that as maintenance as well. Or if they can't tolerate these two, they can be given methotrexate. But that's not your first line. This one's your first line here. Okay, in patients who have surgery, because it's not curative, they still need to have drugs for the first 3 months. Okay, just to dampen down the immune response and so they can get the best, the least symptoms as possible. Okay, you do not give biologics in maintenance of remission. That's only induction of remission, and that's your last resort, really. Okay, right, so we'll quickly move on to IBS because I'm just looking at the time there. So we'll go over it. So I've just done a whistle-stop tour of IBS as well. So your definition, so it's a disorder of enhanced visceral perception. So basically you've got bowel symptoms, but no cause can be found for it. An important thing to remember is it's a diagnosis before exclusion. Okay, so you need to be checking for everything else basically before you diagnose this condition. So it's diagnosed using the Rome criteria. So this is, you've got abdominal discomfort or pain, and you've had that for more than 3 months or more than 12 weeks. And it's got at least 2 characteristics. So it's either the pain's relieved by defecation, you've got a change in stool frequency, or you've got a change in stool form. So for stool form, you can look at your Bristol stool chart there. You must also have 2 of urgency, incomplete evacuation, bloating or distension. You can have mucus on PR or in your feces, and then your worsening of symptoms after food. So I remember in my 3rd year OSCE, I think it was, we had a patient and it sounded like she had ulcerative colitis to me, and then she was saying she was really worried she had family history of ulcerative colitis and really scared that she had ulcerative colitis. And then actually throughout the history you define that it probably was just IBS, and the major thing was that her pain was relieved by defecation. And another thing to remember is that you don't have any symptoms in the night. So that's another major thing for IBS. Because it's a functional disease, your bowel shouldn't be functioning at night. So you won't have any symptoms in the night. Okay. Investigations for IBS, so it should be the same as for IBD really. So blood, you've got FBC, ESR, LFTs. You can also check for celiac disease as well, and TSH, because for your hyperthyroidism you can get diarrhea. A colonoscopy is indicated normally if you've got any features of organic disease, anything that doesn't quite fit in, and especially if you're over, I put over 60 there, but I think it's over 50. If you go on your red flags for colorectal cancer, so I think that's over 60 with any change, over 40 to 60, any change in bowel habit, you normally get IBS as a younger. So your typical patient's going to be a 19 to 25-year-old female. That's what they normally say. That's what they normally have in OSCEs or in your exams in patients. So some treatments, exclusion diets can be tried. Okay, so I know a lot of people with IBS, they do the low FODMAP diet. So that a lot of things that you have to avoid, say like onions or garlic, they're high FODMAP. You can have bulking agents for constipation and diarrhea, so Fibergel. Antispasmodics for any bloating. So you're just treating the symptoms here. You're just giving any medication that might treat the symptoms. Amitriptyline might be helpful in CBT as well, so cognitive behavioural therapy. A lot of the time, IBS is made worse by stress or anxiety. A lot of people who have anxiety also have IBS. So obviously there's not been a distinct cause found for IBS, but a lot of people have found that it's worse if they're really anxious. Okay, I think the most important thing, I've done some red flag symptoms here to remember about IBS. is what doesn't make it IBS. So obviously it's a diagnosis of exclusion. So you've got to think, what would make it IBS? So normally over 40, you don't normally get a diagnosis of IBS. So someone might come in who's 45, but they probably do have a 10, 20-year history of similar symptoms. They might just got worse recently. Need to check for that. Bloody stool, you should not have a bloody stool in IBS. You need to be checking for also colitis really, or colorectal cancer or something else. Anorexia, so don't normally get that in IBS. Weight loss, so you shouldn't get severe weight loss, so that's a red flag symptom. Like I said, diarrhea at night is a functional disease, so your bowel shouldn't be functioning at night, so you shouldn't be having symptoms at night. Palpable mass, that shouldn't be happening in IBS. A raised fecal calprotectin, so that shows if it's raised, that means there's inflammation in the bowel. There shouldn't be any inflammation in the bowel in IBS. There's nothing seen on colonoscopy or anything like that, so that should be raising a red flag there. And then raised CA125, so that's a marker for mostly used in ovarian cancer. So a symptom of ovarian cancer is bloating and just feeling unwell, which people might mistake for IBS. So if you've got a raised CA125, you want to go down the ovarian cancer route. Okay, right, so quickly go over stomas here. So a stoma, the definition of a stoma is bringing a lumen that contains substances to the surface of the skin and allowing those substances to come out into a bag that's attached to the skin. Okay, a lot of people think that it's only intestines that bring, but you can also have different kind of stomas as well. So you always describe it as a lumen. Okay. So, like I said, abdominal stomas are mainly used to divert feces or urine outside the body where it's collected in a bag. So I'm just going to be talking about the three main types of stomas. So you've got colostomy, ileostomy, and urostomy. Okay, and stomas can be permanent or temporary as well. Okay, I don't know if anyone wants to write in the chat what distinguishes each stoma. So what we're looking for when we look at a stoma to figure out what type of stoma it is. Has anyone got any ideas? Oh, sorry, I'll answer that question about IBS at the end there. I didn't see that. Yes, that's perfect. So spouted or non-spouted. That's a great one. Location, perfect, that's great. And then another one that I normally use. Some people forget there. Consistency. Yeah, so contents of the bag. Consistency of stool. Yeah, absolutely perfect. So they're the three major ones I use there. So well done, guys, doing really well. So there we go. So spouted or non-spouted, location of the stoma, and then the contents of what's in the bag. When you're looking at a stoma, you also need to check around the skin for any redness because we don't want any infection in the stoma. Check it's clean. Make sure they're taking care of it there. Okay, so a colostomy. So colostomy is a stoma from the large bowel. So you find it in the left iliac fossa, so the left lower quadrant basically. And because it's like the end of the large bowel is basically what normal feces is, so it's going to be solid feces in the bag if you're looking at it. It's flush to the skin, so if you look, it doesn't stick out or anything like that, so we call it non-spouted. This is because the bowel contents is just normal feces, is not very alkali or very acidic, so it's fine if, obviously not pleasant if a bit gets on the skin, but it won't irritate the skin or anything like that. So like I said, you can have permanent or temporary ones. So the permanent ones is, you might see if there's been a large rectal cancer and there's no way of being able to make a functioning rectum anymore. So the rectum has to be taken out and you make a colostomy, you bring it to the skin, and that's a new way the feces come out. A temporary might be in diverticulitis or in an obstruction. So in a lower left colonic obstruction, or in diverticulitis, so that's on the left-hand side. So that might be just to allow the obstruction to be removed or allow the diverticulitis to be treated for the inflammation to calm down. And then it can be re-anastomosed. The two anastomoses can be rejoined, and then you can have a functioning bowel again. So that's just to rest the bowel. A temporary one can also be a loop, so they can just bring the bowel up. They don't have to make, they just make a little slit in it. They don't completely cut the bowel, and that just allows it to the contents to come out, and that just allows the anastomosis to rest and heal after they've had a surgery. Say for an obstruction, they've removed the obstruction, and it's allowed to rest. Then in the loop, they can just stitch that little cut they've made and re-put the bowel back in its place. So, sorry guys, I'll go quite quick, run out of time. So ileostomy, so that's your small bowel. You find that more in the right iliac fossa, so you see on this diagram here, because that's where your ileocecal valve is. So that's if we remove the whole of the large bowel, so then it's just your small intestine. So it's going to contain liquid because you don't have your large bowel anymore, and that's where a lot of the water is reabsorbed. So these ones, you find that they're spouted and they stick out from the abdominal wall. So they're probably a centimetre or two out of the abdominal wall. It's because there's a lot of enzymes in the large bowel that are quite alkali, and they can irritate the skin if the contents get onto the skin, and we don't want to get any infection or inflammation around the stoma. So you've got your permanent ones, so you've had a total removal of the large bowel for ulcerative colitis, or FAP, so that's your familial adenosis polyposis. And then you can get a temporary one, so if you've had to have, if you've got abdominal sepsis, or you've got a major bleed that needs recovered, so you might have to take part of the large bowel out and stitch it back together. So again, it's just the same with the anastomosis, it just gives the bowel time to rest. Okay, and your last one here, you've got your urostomy. So that's created after your bladder's removed. So you can see on this diagram here, you've got your ureters. You get a small part of the ileum, and it gets attached to the ureters, and then part of that ileum makes the stoma to come out. So it's spouted again because you don't want urine on your skin, and the bag will contain urine there. It's also in the right iliac fossa. So to distinguish between the two, you just look at what's in the bag basically. Is it fecal matter or is it urine? And that's there. And that's everything there, guys. So thanks very much for listening.
Dave, I'm trying to keep it quick. I try and make it a bit interactive as well, because I know it's a bit boring just being like spoken at. But you don't need to put your videos on or anything. You just put stuff in the group chat. I've just got a few questions. So I'm just going to be talking through GI bleeding, and then just a little bit about diverticulosis, and then Meckel's diverticulum at the end. But mainly about GI bleeding, which is just like quite a common thing that you see in hospital, and it's a bit different because it's more like treating the patient in front of you and the symptom of GI bleeding, as opposed to sort of finding what's exactly causing the bleeding. So in terms of what it is, it's just any form of bleeding from the GI tract, from the mouth to the rectum, and it's sort of split up into upper GI bleed, lower GI bleed. And in terms of how they're split up, it's not really that relevant, but officially it's up to the ligament of Treitz. I only learned this yesterday. So that basically encompasses, for an upper GI bleed, it's like the esophagus, the stomach, and then some of the duodenum. I think if you look at that picture there, does it say the ligament of Treitz sort of wraps around the like end portion of the duodenum? So that constitutes what's like an upper GI bleed. And then in terms of a lower GI bleed, that's everything below that. So that's just the small intestine, the colon, like the rectum, and down to the anus. If you've got any questions at all, by the way, just say them at any point. So I just want, just to start, because obviously there's so many things that can cause it, just to make you have a little think. Can you just list in the chat like as many causes as you can think of for an upper GI bleed, and try and list them in terms of like what you see the most often and what are more rare, if that makes sense? I'll just give you a bit of time to maybe do that. Don't worry if you don't know that many. Yeah, nice. Cool. Yeah, so the ones I see in the chat, they're sort of the main ones. Bilateral lesion, yeah, I don't actually know what that is. Cool. All right. So yeah, the main one, as you said, is peptic ulcer disease. So that's really common. You see that quite a lot because it can be caused by a few different things. Erosive gastritis, so that can be caused by a few things, but mainly sometimes. The one that I saw was just really heavy alcohol consumption. But that's just basically irritating of the stomach and the esophagus, which causes just irritation and bleeding. And then obviously there's varices, which are caused by cirrhosis of the liver. Mallory-Wise tear, which is you see sort of in younger people who've like been on a night out and have been vomiting a lot, and they've just had a little tear in the stomach lining. And then sort of AV malformations, drugs I put, but they're sort of just causes of the peptic ulcer disease. And then obviously rarer causes, so you've got that whatever person said in the chat, like DFO lesion and things, but you just won't really see them, to be honest. I mean, in terms of what the symptoms are of an upper GI bleed, have you got any idea of what they are? Just put them in the chat. Not many, to be fair. I've lost the chat. There we go. Yeah, so that's good. But the main one you'll see is sort of hematemesis. That's what they'll come in. That's what they'll come in with. They'll come in with what they describe as, well, they don't really ever describe it as it, but people say it's coffee grounds. Sometimes it can just be a fresh red bleed. Coffee ground is more if it's been in the stomach for a bit longer and it's been digested by the stomach. So that'll be more like your peptic ulcers. Whereas esophageal varices tend to vomit fresh hematemesis. They're the only ones that I've actually seen in real life. I'm not sure about the other conditions, but yeah, it's either hematemesis, and then also what you get is melena. So I don't know if anyone's actually seen that or smelled that, but once you have, you never forget it. But it's just like really black, tarry feces, which have a really, really strong smell. I don't think you'll ever miss it once you've seen it. And then just other symptoms that you need to look out for, which will push you in sort of the direction of a different diagnosis, is for your peptic ulcer disease. They'll probably have a history of dyspepsia, so like indigestion and maybe a bit of epigastric pain and heartburn. Varices, obviously you're looking for some of the symptoms or signs of chronic liver disease, and then some of the other things that just cause a bit of bleeding. There won't be any other signs or symptoms. All right. Oh, and then yeah, someone said anemia, which isn't necessarily a symptom, but that could be a byproduct of it. So what would the symptom be of anemia? Katie. I guess if it's like anemia that's gone on for a long time, yeah, so pale, breathless, palpitations, and just feel quite weak. And then I guess the sign you're looking for is under the conjunctiva, which will just be pale. Yeah. So these people who've had a big bleed, will just look really, really pale. I'm sure you've seen them, and they just look off color. So there's some nice pictures of it. So that's melena on the left. And then that's like the definition coffee ground vomit. You don't really see it like that often. But I've seen you sort of see vomit mixed in with fresh blood, and then yeah, you do see that. But so you can see that that's blood which has been sort of semi-digested to coffee ground. And that's why it appears like that. Right. Did you want to do the same thing? Just have a little think quickly before I show you the list of just what causes low GI bleeds. I think you probably saw quite a few of them with Robyn. Just have a little think. I'll just give you them and just put a few in the chat. Try and think of which one's the commonest. There's, I think, A lot of the time it's just 2 of the same ones. Yeah, good. Any more from anyone else? Yeah, good. AVM, diverticulitis, yeah. Yeah, so they're the main ones. So there's so many causes, to be honest. I think the thing that you'll realize from this talk is when you're dealing with the upper GI bleed or a lower GI bleed, it's not necessarily the most important thing for you. I know it's fine you need to know what the conditions are, but if you're the F1, which isn't actually going to be in that much time, it's mainly more about the patient, how the patient is and how severe the bleed is, and sort of stabilizing the patient. It's not really your job to see that they have a bleed and work out exactly what it is, because there's so many different causes, and they're going to end up having an endoscopy from like the gastro team anyway. So just in terms of looking at causes though, the main 2 causes are diverticulosis, like diverticular disease, and AV malformations. And I've read that that constitutes 80% of lower GI bleeds in adults. So they are the really 2 common things, and they're the main things you're going to come up against. But obviously it's about ruling out. You need to rule out the more rare things and the more things that are quite severe and insidious. So obviously like inflammatory bowel disease, ischemic colitis, hemorrhoids, and then obviously in your older age group, you'd be looking for colorectal cancer. But in terms of a patient that you'd be looking at for colorectal cancer, can you give me a few sort of red flags in the chat about what you'd be looking for and what would be maybe pushing you towards more of a diagnosis of colorectal cancer as opposed to maybe just a different cause that would get you a bit more worried? Yeah, good, exactly. So you're looking for those B symptoms, aren't you? So I can't remember exactly what they are, but it's weight loss that they've not really tried to do. Fatigue, tiredness, what are the other ones? I can't really remember. But it's more in that over 65 group that you'd be a bit more worried. And yeah, obstruction. I actually saw that. So I've been on the acute, on the AEC, and this lady came in who literally, she didn't actually have any bleeding. Well, she had like she had like an occult blood positive test, and then she was supposed to come in for like colonoscopy and OGD, and she was just lost to follow up, I think because of COVID. I think that was back in November. And then she came into the ambulatory care department, and she hadn't been to the toilet in a few days, and she just had some abdominal discomfort. And they like expedited her CT scan, and she had one in the following afternoon, and it showed bowel cancer had caused like a small bowel obstruction, and she had like metastasized all over to her liver and her lungs. So I guess that's a bad part of what's happening with COVID. But yeah, obstruction is quite common with cancers. Then obviously there's the rarer ones, which I don't really need to know about. So in terms of symptoms for lower GI bleed, it'll be sort of darker blood mixed in with stool or like a fresh bleed. It won't be pure melena, because obviously that indicates that it's more of an upper GI bleed, because obviously the blood needs to be digested and fully mixed in with the stool. So what patients will describe is that they've had like blood splattering in the bowels, like that, or they'll have, if it's a bit higher up, then you can have a bit of fresh blood mixed in with stool. And the symptom is hematochezia, which has blood, like bright red blood in the stool. All right, so just to break things up, just to think of a little bit of a case. So if you're the FY1 in A&E and your consultant asks you, which isn't too far away, so it's good to start thinking about this. And I think, because obviously it's like based on Oscars as well, so this is kind of thing that you'll get. And so your consultant asks you to make an initial assessment of like a 65-year-old man presenting with blood in his vomit who's currently clinically stable. So do you want to just have a think and put in the chat maybe what a few questions that you want to have, that you want to ask initially in the history to get a bit more of an idea about what's going on. Because that's all the information you really get given, to be fair. You just get a little snippet of why they've come in. So you need to then obviously use your history to try and get a better idea. Yeah, cool. Yeah, yeah, definitely that. Yeah. So that sort of history of presenting complaint. What other parts of the history would you want to ask questions about that are important in a GI bleed? Yeah, exactly. Alcohol history, that's really important. One other part of the history that you usually take after, yeah, history, other diseases important. They might have like a history of cirrhosis. And then what's really important, actually, one case that I saw last week, so one that's really important to take a good history of. You usually take it after the past medical history. Yeah, exactly. So what meds they're on. That's really important because obviously medications can cause peptic ulcers. All right, that's good. So I just put a few key things that you want to look for in the history. So obviously duration and quantity of bleeding. So it's important to get an idea of how much they have been bleeding and how many times, and what the type of bleeding is, if it's melena, hematemesis, hematochezia. So then you want to look at all the associated symptoms. You want to ask your red flag questions. So you always want to ask in any history that's sort of GI related about the weight loss, tiredness, weakness, fatigue. And then you want to quickly ask some questions about, I mean, you get this from the nurses before you go, because every patient that comes in will have like observations done. So they have their news chart. So you'll be able to see initially if they're not hemodynamically unstable. And if they weren't hemodynamically unstable, I don't think you'd be clerking them. But you can just ask if they feel dizzy, short of breath, and they feel weak, just to get sort of an idea of if they've lost a lot of blood and it's sort of starting to affect their circulation. You just want to know also about previous history of bleeding. So it's good to take a past medical history. Known, so if they've got known liver disease, it's obviously important to know that, because that's going to push you more towards a different that diagnosis of varices. And if they've got history of ulcers, it's more likely that they've had recurrence of them. And then a really, really important one that people miss out and don't do a good one on is the medication history. So what drugs? So someone already said it. So the main drugs that you're looking out for, sort of NSAIDs, aspirin doesn't, not so much cause, I think it can still cause it. But it's steroids as well, and SSRIs apparently can incline you more to have a peptic ulcer. These happen quite often. I saw one in hospital last week of a guy, was like 60-year-old guy who just hurt his shoulder and gone to the GP, and they'd started him on a course of naproxen, I think, and he was only supposed to take it for 5 days, but he ended up taking it for 3 weeks, and he just presented with like upper hematemesis, upper GI vomiting. And then also you want to know about serious like comorbidities, because that's going to put them more for a, that's going to incline them more for like a bad prognosis. So heart disease, renal failure, liver disease, etc., etc. All right, so the key points in the history that it started this morning, had 2 cupfuls of bright red blood, hasn't happened since, and he rarely sees his GP. His past medical history is fatty liver and his drug history is nil. And you find out in the social history that he drinks 80 units of alcohol a week, and he has been doing this for quite a long time. So in terms of, now you want to obviously examine him, what system would you want to examine, and what are you looking for on examination? Don't just pop what you think in the chat. We'll just have a think about it. Yeah, so gastro exam. So what other examination is really important to do for all these patients after you've done a gastro exam? Not the most pleasant of exams. Yeah, so you really need to be doing a PR on all of these patients. And in terms of this, yeah. So yeah, on examination, I'd want to be doing a full gastrointestinal examination. You'd probably also be having a listen to his lungs and his heart, as you would with most patients. And then it's really important to do a PR exam on all these patients, even if it's an upper GI bleed, because mainly want to look for evidence of melena, to be honest. So you want to be looking for signs of chronic liver disease. And obviously, you want to probably be doing an assessment of their volume status. So you want to assess if they're shocked how much blood they've lost. So the main things that will help you look at that is looking at their cap refill time. Obviously looking at their observation charts, feeling their hands if they're cool and clammy, if they've got a weak pulse. All right. So you examine him, there's nothing really to find apart from this examination finding, which looks a bit strange. Does anyone have any idea what that is? Yeah, so that's caput medusa. So that is varices in the abdomen. So that's going to be pushing you to more of a diagnosis as this person might have a serotic liver. So just quickly, because they do always ask about these, and I don't know why, but they're sort of important to know, even though you don't really see them that much. But can you just have a think about any other peripheral signs of chronic liver disease that you'd be looking out for in this patient once you've seen that? I know there's loads of them, but maybe just try and put in a few into the group chat, or just have a think about it. Yeah, exactly, good. So there's loads, but yeah, you've got the main ones there. The important one is jaundice. Which will probably put in the his examination findings, but that is one of the first ones that you'll see. And obviously it's really important to look in the eyes and at the sclera, because that's what will become obvious first, either to the start of them having like a high bilirubin. Clubbing's quite a late sign. I don't think you'll see that early. Spider nevi, not really seeing many of them. And then yeah, obviously caput medusa. Oh, that's an important one to look at. The asterixis or the tremor as well. So this chap goes for endoscopy, and that's what it looks like. So I don't know if you've ever seen a picture of varices. I mean, that's quite severe esophageal varices. But as you can see, they're just really, really sort of dilated vessels, dilated veins that have all backed up and are at serious risk of just popping and bleeding. And as you can see, they're so full of blood that the risk is when they pop, they really can go. So in terms of the mechanism of developing esophageal varices, I think I already mentioned it earlier, but it's a byproduct of the cirrhosis of the liver. So I'm sure you all know that you have your portosystemic blood flow system, and a lot of blood goes through the liver. And so when you get your cirrhotic liver and it all fibroses and it just can't travel through very well, this is how I understand it anyway, all that blood just can't flow through as well anymore, and it all backs up. So all the veins throughout your body just fill with blood and they become dilated and they're at risk of just popping and bleeding. I'm sure it's a bit more intricate than that, but that's just how I think about it. All right, so you've taken your history and examination, and you sort of think this guy has varices. You think maybe he's going to need an endoscopy, but what do you want to do next? What sort of procedures would you want to do on this chap? Not in terms of procedures, actually, just like what sort of test do you want to do? Yeah, cool. Yeah, so the main thing that you're going to do when you see this patient is blood tests, and then consider endoscopy, exactly. So realistically, yeah, that's pretty much all the blood you do, actually. So what sort of things would you potentially see on the full blood count if he'd had a big bleed? Or this goes for any patient, because you're going to do the same set of bloods, really, for any GI bleed. So what sort of things could you see on the FBC? Yeah, exactly. So you're going to see a low HB, and that's going to end up sort of guiding your treatment for it. So if they have a really, really low HB, that's going to get you a bit more worried. So if it's in the sort of 60 to 70 range, that's when they're probably going to be having a transfusion quite soon. And then on the U&E, there's one thing that is good to look out for, which is usually associated with kidney disease, but actually goes up in an acute GI bleed. More an upper GI bleed, to be fair. Does anyone know what that is? Pyorrhea, yeah, exactly. Do you know why that happens? Yeah, exactly. So I think sometimes people can get a bit caught out because a patient comes in and they have like a raised urea, and if they haven't come in with obvious source of bleeding, you can sometimes think that that's due to the kidneys going off. If you have a raised urea without a raised creatinine or a decreased EGFR, it's like really important to start thinking if they have like an upper GI bleed somewhere, because basically they're just digesting the blood, which is just a rich protein meal, and a byproduct of that digestion is urea. So your urea goes up. So the classic picture of a upper GI bleed would be a HB drop from their baseline and sort of like a raised urea, and that would be definitely putting you in the direction that this patient has a bleed and that they're probably going to need to go and have an endoscopy. Trying to think what else I've put. Yeah, so these patients, you obviously just need to monitor them really closely, especially the ones that have varices, because they can just if they have a big bleed, they can just go off like really, really quickly. So the nurses obviously be doing that, but they'll be doing the observations and the news regularly to make sure that they're not having more bleeding or going into shock or becoming hemodynamically unstable. So that'll probably be hourly or even half hourly. And then the bloods you want to get, which you already mentioned most of them, the FBC uni, LFT, and then obviously we didn't mention the LFTs. But that'll obviously show you if the patient's serotic or if it's due to the liver, and obviously we'll push you in terms of varices causing their upper GI bleed. You want to get clotting, because obviously if their clotting is poor, then the bleed's going to be more severe. Can anyone think of a reason why or how the clotting would be deranged? I guess it's more to do with a condition that we've already spoken about, which causes poor clotting. Anyone got any ideas? I don't know if that was a badly worded question. So it says, what I'm thinking of is just like cirrhosis of the liver. So cirrhosis of the liver, obviously all your clotting factors are made there. So it's a good way of checking how poor the liver function has become by having a look at the PT and the APTT. That shows that the liver's really not functioning well, and that this patient might not do very well because obviously their clotting factors are off, and they might end up needing something like fresh frozen plasma and things like that. And also, one thing that's really important is you need to do a group and save and a cross match on these patients, because you need to do a group and save so you know the blood type, and then probably need to cross match them some units of blood depending on how much blood they are losing, because these patients can just have a big bleed suddenly and then just become really ill very quickly. You want to have them have 2 big cannulas in them, even though they might not be unwell at that moment. It's just in case anything does happen that you have good access. Might start them on some IV fluids, and then these patients need a referral to gastro quickly. So in terms of varices, I think they say they want to do endoscopy within 4 hours if it's severe or like quite urgent, and then with other types of bleeding it's not so urgent. So yeah, we already talked through what abnormalities you'll see on the blood. Oh yeah, so I don't know if anyone knows, should have probably asked, but so this is what they use quite a lot to stratify the risk. So I guess patients will come in with a GI bleed, and some patients need to be in hospital admitted, and some patients can actually have their treatment as an outpatient. And this is all dependent on different things. So what they use is they use the Rockall score, and they score these patients, and it just stratifies their risk of their outcomes from coming in with a GI bleed. So as you can see, score 0 is sort of that, and then it gets higher and higher for the big comorbidities and increasing age, and if their blood pressure is going down, if they're going into shock. So obviously the higher the score, the more urgent these patients need to be seen by gastro and need to go for their endoscopy. And the lower the score, these patients might be able to wait 24 hours, not so urgent, and might even be able to go home and come back as an outpatient. And then the Glasgow Blatchford score is sort of similar, but it uses actual blood tests, and then it's more to also stratify if patients are candidates for an outpatient endoscopy. So as we said, it uses the blood tests that we spoke about, so urea, hemoglobin, their blood pressure, and then the presence of these diseases. So if they score high on that, then they need to have one quite urgently. If they score 0, or no, if they score low score, so like 3 or 4, so the urea is quite low, their hemoglobin stable, their blood pressure stable, they haven't got any liver failure, cardiac failure, or signs of hemodynamic instability, such as syncope or a high pulse. These patients can actually sometimes be sent home and brought back in the next day or for an endoscopy. So that's more, it's not that important for finals, but that's more once you actually start working in hospital in terms of like which patients need to be seen first and prioritizing the urgency of them. So this is this is not like an official guideline, but I think you get used to just following these guidelines for like upper GI bleeds and stuff. You just read through that. You just sort of follow a little pathway about what needs to be done when. So if it's a minor bleed, sometimes they can just be seen electively and brought back in. But if it's a major bleed, they need to have a endoscopy early and need to be treated for whatever's found on endoscopy. They don't really need to go into the details of that. That's more gastro. So just a quick sort of little case for you to think about just in your head. So the patient's transferred to the ward for endoscopy in the evening, and while on call you get a bleep from the nurse saying the gentleman with the blood is vomiting a lot more. Could you come assess him urgently, please? So I actually saw a case quite similar to this a few weeks ago. So when you really think about it, you don't really need to think about it too much yet. But what sort of questions do you want to know? What other information do you want to know over the phone before going to see this patient, which will sort of give you an idea of how urgent you do need to see them? Although this is quite urgent anyway, you would need to see them quite quickly. Yeah, exactly. So what their obs are, that's the most important thing. And I just asked like how concerned she is as well. Because that usually gives you a good idea of how quickly you need to go see them. But I mean, you'd probably be seeing this patient quite quickly anyway. So the observations are, so she tells you down the phone that rest rate's 18, the BP's gone down to 97/60, previously 120/76. His heart rate's gone up a bit, he's slightly tachying, his SATs are 97% on room air. And you ask her how concerned she is, and she says she's really concerned. He's starting to look very pale and is confused. So you've got a few signs that the patient is getting quite unwell. So what would you like to do? So I think it's quite obvious that you want to go see this patient really quickly. And so you get to the patient's bedside. He's got a bowl in his hand, which has got quite a lot of fresh blood in it. There's a few nurses around doing his observations. Everyone's quite stressed. So what do you want to do first as the F1 who's just approached this patient who's obviously quite unwell? Yeah, so call for help, that's good. But no one's there at the moment. Your reg is busy on the phone with another cardiac arrest. So it's just you for the time being. So what do you need to do in the initial phase before the help can come? So you've called for help, so you've put out a met call, but it's going to be a few minutes and this patient's sort of going off. What can you do in the first instance? Yeah, exactly. So A, B, C, D, E. I think that's. I think when I was speaking to one of the F1s at the moment, and they were like, the on-call job is basically just being like a professional A to E person that just needs to get really good at that. And you're basically just like a screening tool for the most ill patients to get help for. So yeah, you want to basically, you see this patient, his news is it's going up. It's probably like, I can't work it out, but it's probably like 5 or 6. And you see that he's actively bleeding. You probably, if your hospital has one, you'd want to put out a met call straight away. So you'd go in, you'd be like, nurse, can you put out a met call? And then you do your A to E. So the most important thing is to make sure the airway is patent first. So you might have a lot of blood in there, so you might have to utilize suction, although the nurses are really good, so they'll probably be doing that already if you need suction. You want to try and put some oxygen on him, even though he might be vomiting. So at least try and put some nasal cannula in, or preferably high flow oxygen. Obviously, that's difficult if he is actively vomiting. You want to do B, so check the breathing, check his rest rate. Although the nurses will be doing these around you. So you check again, and now it's 92% on room air, so you definitely need that oxygen. His BP is going down even more, so 90/60. His heart rate's going up higher, 120. You check his CRT, and it's more than 3 seconds, and he's cool and clammy. So the most important thing is here, he should already have access, but if he's only got, like, a lot of the times they only just have like 1 blue cannula in, so this guy needs like 2 large bore cannula, like at least a green, like preferably a grey. And you want to get fluids into this guy like as quick as possible, because obviously his BP is going down. And at this point, hopefully the Met team arrives, and this guy's sort of peri-arrest. So hopefully they might have some O negative blood potentially getting to him quite quickly to put that in. So you want to put those cannula in, and you want to take off some bloods, so some fresh bloods, and you want to cross max 6 units of blood, and they want to get those to come down quite quickly. But the main thing here is you just need to call for help early, because there's not much that you can do, because this patient needs a lot of blood and he needs an urgent endoscopy. And if it's a variceal bleed, they can sometimes put down that there's a like Blakemore sounds taken tube or something, but I'm pretty sure. All right, nearly done. So in terms of management of upper and lower GI bleeds, the mainstay of treatment is if these patients, the main thing that you need to worry about as like an F1 is just making sure the patient is stable. So giving them like aggressive resuscitation and getting help early. And then they just need an endoscopy really. So if that's an upper GI one or a low GI one, to sort of see what they're dealing with. If the patient has like a suspected variceal bleed, they put them on terlipressin, which I think reduces pressure in the portal system or something. So it might reduce the risk of a really big bleed. And then obviously on endoscopy, I don't think you need to know too much about the ins and outs of it, but they can do band ligation and injection sclerotherapy for the variceal bleeds. And then obviously for peptic ulcers, they'll be looking for H. pylori. And then the treatment of H. pylori eradication, I think it's like amoxicillin, clarithromycin, and PPI. And then the other thing they'll be looking, and then obviously if there's a lower GI bleed, lower GI bleeds tend to be less acute and can take it like be a bit, you have a bit of time. The ones that are acute in hospital and the patients like can go bad really quickly is more the upper GI bleeds. So lower GI bleeds, they'll be just having a colonoscopy to just find the cause. And obviously if they find a colon cancer, that's going to be a referral to the surgeons. All right, so nearly done. So I think the part of this talk was supposed to be on diverticular disease, but it's going to be very briefly about it. The diverticulosis is really, really common, something that you'll see like all the time in the surgical admissions. And it's basically just outpouchings of the bowel wall. And diverticular disease is how you describe it when it becomes symptomatic. So the risk factors are sort of age, low fiber diet, and the history of presenting complaint. How these patients will present is that they've had like a bit of an altered bowel habit. They've got this like colicky left-sided abdominal pain that comes and goes, and there's not much you can do for it really. It's more just supportive management if it's not severe. You can kind of give like a high fiber diet apparently, but there's not much you can do. And then diverticulitis is obviously when the outpouchings of the diverticula can just get infected really. So yeah, that you get more pain in the left iliac fossa usually, although it can be in different areas of the bowel. So if it's not in the left iliac fossa, it still can be diverticulitis. So they'll be off their food, potentially a bit nauseous, just infective symptoms, so they can have a high fever, things like that. And in terms of treatment, I think for mild, you can just give some oral antibiotics. And then if it's really severe, you can have hospital admission and you can give them IV fluids and IV antibiotics. And sometimes these need a temporary stoma, but I'm not too sure when that's indicated. I've not seen that. Usually these patients like leave hospital quite quickly, and they're usually fine after a few antibiotics. They just have a few flare-ups every now and then. And then Meckel's diverticulum, I literally didn't really have any idea what this was until I looked at it this morning. I've never seen it, but it's a congenital diverticulum in the small intestine. I looked at PassMed and it said there was a rule of 2. So it's in 2% of the population, 2 feet from the ileocecal valve, 2 inches long. And I think these patients tend to present in pediatrics. So they have abdo pain in the right iliac fossa, and they can present with rectal bleeding. So apparently it's a common cause of painless massive GI bleed in a child aged 1 to 2, that's supposed to be, not 1 to 20. And it can cause an obstruction. I think they manage this by removing it if it's got a narrow neck or it's symptomatic. But I wouldn't worry too much about Meckel's diverticulum. I don't think you really get tested on it. I mean, you need to know a little bit about it, but all right, I think that's pretty much the end. I just want to say tips. I think most people probably doing their finals this year that are on this. And just in terms of, I thought I'd just put a bit of tips of what I did. So that's what I just got recommended by people in the years above me to do. And you've probably been told this already, but they just said, and I think this did come out in the finals, just need to know like a lot. So you need to know the ins and outs of the really important common diseases. So the things that you see like week in, week out, you know, so like your asthmas and your common bowel diseases and just like the core cases. You just need to know ins and outs, like the pathophys and how you treat them, and even like second, third line. So know them by the back of your hand. But then about all these, like, I feel like people get caught up on spending a lot of time on the random things like Meckel's diverticulum, and it's obviously good to be aware of them, but they're not going to be worth a lot of marks. Like you might just get like a random question on them. So I think doing PassMed is really good for like getting those random MCQs right. I wouldn't spend hours like just learning about them. Yeah, I think you'll be fine. All right. Cheers, guys. That's